Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in OBGYN will answer your questions from bump to birth and planning for pregnancy. Well, thank you so much for submitting your questions in advance. And the questions that you'll hear me asking the providers are all submitted questions right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, which include Dr. Whitney Jolitz, Dr. Cheryl Yondorf, Michelle Barkus, a certified nurse midwife, and Dr. Mina Condowell. Well, thank you so much all for joining us. Before we dive into our questions, I'll give each of you a minute or two to say hello and just provide us some background about yourself. So Dr. Jolitz, we'll go ahead and start with you. How are you doing this evening?
I'm doing great. Thanks for everyone for having me. As Sarah said, my name's Dr. Whitney Jolitz. I currently work at Jefferson OBGYN, New Jersey. I've been there a little over a year, very happy. Been practicing for about 6 years in total. Just an introduction to Jefferson, New Jersey, OBGYN. We do have 3 offices, Stratford, West Deptford, and Washington Township. We have a full team of midwives, OBGYNs, and a handful of nurse practitioners. So we'd love to have, if anyone's looking for care in New Jersey, we have plenty of room for you.
Great. Well, thank you so much. We're excited to have you. Okay, Dr. Yondorf, how are you doing?
I'm good, thank you. I am a general OBGYN who works out of Jefferson Einstein Hospital in Philadelphia. I have been at Jefferson Einstein now for 10 years, actually. I'm from New York originally, did med school back in the Bronx, and then came over to Jefferson Einstein for residency, and then stayed on here as an attending afterwards. And I'm very excited to be here.
Great. Well, thank you so much. Okay, Michelle, thank you so much for joining us this evening. How are you doing?
I'm doing well. Thank you. Thank you for having me. I'm Michelle Barkus. I'm a certified nurse midwife with Jefferson Einstein Montgomery. We have several offices as well, like New Jersey does. We are in King of Prussia, East Norton, and Norristown and Collegeville. I've been with Jefferson Einstein going on 8 years now, and actively practicing for about almost 20 years. So it's been a long, fruitful career, and I'm happy to be here.
Terrific. We're happy to have you. And last but not least, Dr. Condowell, how are you doing?
Good, thank you. Thank you for having me. I have to say I'm the youngest at Jefferson here, but the oldest practicing. So I've been at Jefferson now, this is my 3rd month, but I've been practicing maternal fetal medicine for 31 years. So long experience. I just started here as a division director and hope to build this program to new heights in academics at Abington Jefferson. We also have campuses in Lansdale, and I'm really excited to be here. My passion is taking care of pregnant women who think they can't get pregnant or cannot carry a pregnancy. So I love to take care of pregnant women and love to see them have a healthy baby and have a healthy outcome for themselves as well.
Amazing. Well, thank you so much. And we're thrilled to have you at Jefferson. So thank you for joining. Okay, well, with that, let's go ahead and dive into the questions because I know we've received a lot. So without further ado, question number 1, Michelle, I'll direct it towards you. What are some things to prioritize for mental and physical health when trying to conceive?
That's a great question. Preparing for conception is really prepping your body and your mind for this amazing, long, event. Think of it as a 40-week marathon. You have to train for it, and you got to train long and hard beforehand. So making those changes to your physical well-being that you've been intending to do. So starting to exercise, get fit, nice, well-rounded diet, make some improvements in your nutrition profile is really key. Reducing stress is also super important. Mental wellness, as we all know, is a key component to our overall health and well-being. So starting to prepare yourself, your mind and your body before you get pregnant is really important.
Absolutely. Okay. Thank you. All right. Dr. Jolitz, we will turn to you. This question submitted asks if there are any specific tests that my partner and I should look into before trying to get pregnant, such as potentially a genetic test.
Yes, I actually really liked this question because it brings up preconception counseling, which would be a visit with your provider before you get pregnant, which I definitely don't see enough of. Most patients come in pregnant, sometimes it was unplanned. But when they come in for that preconception counseling, it's a good time to really sit down, look at your medical history, make sure you're medically optimized or in good health, or if there's things we can fix beforehand. And one of the things we bring up is genetic screening. So we can screen you, or we can offer you to be screened for a variety of things you might carry or certain diseases. And there's some basic testing, and there's also some extended testing. So we can get in a lot of detail with those. And it's important because if you carry something and your partner carries that disease as well, you could pass it on to the child. So ideally, we'd like to know that information before you get pregnant. A lot of times it's offered at your first visit, and those are things we can kind of work around. But if we know ahead of time, you can be counseled and we can be prepared with that information. And in some circumstances, it might be a severe disease where you might seek infertility treatment or IVF, where you can have the embryo or baby tested before to know if it carries the disease as well. So it's luckily something we don't see a lot, but for some couples, it could be pretty important. So especially if you have a family history or a genetic disease you're worried about, I would definitely recommend preconception counseling and get that testing beforehand. Something else we would talk about at a preconception visit would be immunity status. So checking to see if you were immune to certain things, vaccines you would have gotten in the past. Because ideally, if you're not immune, we can get you immune to those before you get pregnant. There are some vaccines we can give during pregnancy, and there's some we can't. So that would be another thing, particularly for the mom to be tested for before pregnancy. But again, those are things we can check for when you come in for a first visit as well. And like I mentioned, medical history is important as well. So if you do have some medical issues, those are things too that, to come in and be tested for, or to make sure that those diseases are well controlled before you get pregnant.
Okay, absolutely an important question. So thank you. Okay, Dr. Yondorf, question for you here. Once you know you're ready to have a child, what are the 3 to 5 most important steps to take?
All right, so that's also a really good question. And I think that part of what I'm going to say really will mirror what Dr. Jolitz said as well. So good to know we're all on the same page here. First and foremost, I really recommend that when you're even starting to consider that you might want to get pregnant in the near future, go ahead and start taking a prenatal vitamin because, one of the things that happens, or the first thing that happens once you conceive, is that the neural tube starts to form. And the neural tube is basically that basis for the brain and the spine. And that forms even before you know that you are pregnant. And so in the prenatal vitamin, there's tons of different things in there, and they're all helpful throughout different parts of the pregnancy. But in the very beginning, folic acid is, majorly important to help make sure that that neural tube forms normally. And so you actually want to have that folic acid in your body, in your system, before you'll even know you're pregnant. And so going and starting to take that prenatal vitamin from the very beginning, when you're even just starting to think about it, is a great idea, so that you have that folic acid in your system ready to go. And, the general recommendation is that you'll want 400 micrograms of folic acid, and that is pretty much the standard dose that's in any prenatal vitamin. You don't need a prescription prenatal vitamin. Pick one up over the counter, just look at the ingredients and make sure there's 400 micrograms of folic acid in there. So that's kind of step number one is, make sure you get that on board. Next thing I would also recommend, and this is where Dr. Jolitz already kind of mentioned this already, is that you want to make sure that you go and you see your primary care doctor so that you can get every medical condition you have optimized. And, you know, a lot of us walk around and life's busy. Who has time to go see their PCP? And so you don't even know that you might have some of these conditions going on because a lot of these things are pretty silent. And so going to your primary care doctor, getting checked for high blood pressure, diabetes, thyroid disease, depression, or if you know you have any of these conditions, making sure that they're well controlled on whatever medications you're taking and reviewing whatever medication you're taking, making sure that the medications you're on are actually safe medications to be on during pregnancy, because often we can switch medications around so that the medicine that you're on to control your chronic condition is something that's safe to take during pregnancy. And so getting to your primary care doctor with enough time to optimize these medical conditions, get on the right medications is really important as well. And then I guess one of the final steps I would recommend is starting to track your menstrual cycles, because one of the hardest things when it comes to getting pregnant is figuring out the timing of everything. Our bodies are really interesting. And when we ovulate, when our egg comes out of our ovary, that egg only lives for 24 hours. And so it's a really short window in order for that egg to get fertilized, in order to be able to conceive and get pregnant. And so knowing what your menstrual cycle is and knowing when you're going to ovulate really helps minimize the frustration when you're trying to get pregnant. Because if you're doing all the things you think you're supposed to be doing, but you're really missing that 24-hour window, then you're not going to conceive. And it's such an easy fix to have and could save you months of disappointment if you already know what your cycle is and know what your timing is supposed to be. And so in general, the idea is that a woman will ovulate about 2 weeks before her period comes. And so knowing how long your cycle is helps you figure out, at day number 14 is when I'm going to be ovulating. So I want to start having sex a couple days before that so that there's sperm in the area ready to go, ready to fertilize that egg when it comes out. And if math is hard for you, there are ovulation predictor kits that are out there. You can buy them on Amazon in bulk if you'd like. And it's basically you pee on a stick every day. And one of those days, that stick will turn positive. And that's kind of, gives you a 24 to 48 hour window of you're going to ovulate within those next, day or two. And so that's when you know to start, having intercourse.
Okay, thank you. Some really important and actionable steps there. So I appreciate you sharing. All right, moving along, we're going to talk a little bit about miscarriages here. Dr. Condwell, how long after miscarriage can I begin to try and conceive again?
That's a very good question, because having a miscarriage is a very tragic event. And, studies have shown that women mourn a loss, whether it's a miscarriage or a termination, for a long time, maybe forever. So it's very tragic. So first thing I would say is you have to be mentally ready to have another pregnancy. Some women are ready right away. Some, are not ready. They need time. So I think it should be very individualized. The second important factor to look into to decide timing of pregnancy is your age. So if a mother is, say, 24, you have time. Take your time. There is no rush to go into another pregnancy. It's okay to wait. Whereas if, let's say, you're 38, then, the chances of you having a miscarriage are higher, but you don't want to wait too long. The timing is very variable. You'll talk to different doctors, they'll give you different answers. But the bottom line is there's no real research study to show how much time you should wait. We usually say wait for one normal period, or longer if that's the time you need when you are ready to have a pregnancy. But there is really no evidence to show that you should wait longer than that if you don't want to and are ready to have a baby. And especially if your age is more than 35, I would recommend trying sooner rather than later.
Hey, thank you. All right. Michelle, turning to you here, know that Dr. Yonder mentioned a little bit about tracking periods. So this question here, how can women with irregular periods better track their cycles when trying to conceive?
Well, to mirror what Dr. Jondorf had mentioned, using those ovulation predictor kits are really helpful. Tracking your cycle with those menstrual apps, they're pretty user-friendly. And truly, if your periods are irregular, it is something to investigate a bit further. How irregular are they and why? And so that should prompt a visit to your care provider as well to investigate it further.
Okay, thank you. All right, let's talk a little bit about PCOS. Dr. Jolitz, any tips for someone trying to conceive with PCOS, and how long before wanting to get pregnant should someone with PCOS get their fertility checked?
So PCOS, for any of the attendees who might not know, stands for polycystic ovarian syndrome. And it's definitely not uncommon. Women who have this experience very irregular periods, or they can. And that is because they don't ovulate regularly. They can have polycystic ovaries, where the name comes from. Patients can also experience, it can lead to increased weight gain, insulin resistance leading to diabetes, high cholesterol. It can have some other medical diseases associated with it. PCOS, if you're not ovulating regularly, it can be very difficult to get pregnant. The first thing I recommend any patient with PCOS is, like we've talked about, optimizing or getting any medical conditions you have under control. If you do have diabetes, making sure your blood sugar is well controlled, high cholesterol, any of those things, really trying to focus on that. The other thing is weight loss, which is easier said than done. Studies show even like 5 to 10% of weight loss can help you regulate your cycles, which means now you're ovulating regularly. So really important things to do before you even try to conceive. When I look at patients with PCOS, I kind of look at what their periods are doing. And I have some patients who have pretty regular periods. And if that's the case, and they're, like we mentioned, and they're younger, maybe they want to try for a year or 3 to 6 months. And I don't think that's unreasonable. Now, if your periods are really rare and you're not ovulating regularly, you're not going to get pregnant, or it's going to be very difficult. And if you're older, so, you might be someone who says, I, want this addressed quickly. And that might be someone where I say, let's do that infertility workup. Let's be more proactive about this. And I have other patients who say, I'm okay with trying for 6 months and let's see what happens. I've had plenty of patients with PCOS get pregnant on their own. It doesn't mean you can't get pregnant. It just might take a little bit longer or might be a little bit more difficult. With PCOS, if your periods are irregular, it can be difficult to track your ovulation, like Dr. Yarndorf was mentioning. So that can be difficult too. So that can be very frustrating. But it's really up to the patient and their goals and their age and what their periods look like. For fertility treatment, a lot of times all you need is ovulation help. So simply taking a pill that most general OBGYNs can prescribe to help you ovulate sometimes is all you need. And if you need more, then we would, refer you to an infertility specialist.
Okay, thank you. And along the same line, Dr. Jondorf, how long should you try to get pregnant naturally before visiting your doctor?
So the general recommendation is to try for about a year before going ahead and visiting your doctor. And the reason for this is because even if everything is working 100% right, you're ovulating regularly, you're having sex at the right time, your uterus and tubes are normal, his sperm is normal. If everything is perfect, you still only have a 20% chance of pregnancy with each month. And so, it's normal not to get pregnant that first month that you try, and that's okay. But by the time we hit a year, 85% of couples have already been successful at conceiving. And so once we're at a year, that's kind of the time to say, maybe something's up. Let's see if there might be something wrong getting in the way of me being able to conceive on my own. And so that's generally the recommendation is after a year of trying, go ahead and see your doctor to see about what can be done. Now, of course, a generalization is just that. It's a generalization, and there are reasons to come see your doctor earlier. Like Dr. Jolitz was saying, PCOS is a big one. So basically, any condition that you might have where you don't ovulate regularly. So if you have irregular periods, even if you don't know why they're irregular, like in general, don't wait a whole year if you're only going to get 2 periods that year, because that's a big waste of time. If you have PCOS and so you're not ovulating regularly, same kind of idea. Waiting all that time is just a big waste, because it's not that you can't get pregnant because something's wrong. You can't get pregnant because you're just not ovulating and you need help with that. And so any condition of that nature, I'd say you can certainly try for 3 to 6 months on your own. And that's perfectly reasonable and appropriate, because exactly like Dr. Joel had said, plenty of women with PCOS will get pregnant on their own without any help. But once you hit that 3 to 6 month mark, or really 6 months in general, but if you're anxious, you can certainly come sooner. That's when, we recommend coming on in. And also women who are over the age of 35, if you've been trying for 6 months, that would be a time to start seeking help, primarily because after the age of 35, it does become more difficult to conceive. And so if you are somebody who's going to need some help getting pregnant, waiting a whole year is wasting a little bit of time. And, after the age of 35, every year kind of counts in your ability to be successful with fertility treatment. So if you do need that fertility help, if you waste, so to speak, that whole year trying on your own, you really are wasting kind of precious time. So 6 months is appropriate, because you really can get pregnant on your own. But after 6 months is when I would recommend coming to see somebody once you're over the age of 35.
Okay, thank you. And adding on to that, Dr. Condwell, if a couple is struggling with fertility, what should be their first steps then towards becoming pregnant?
This is a really important and good question, because there are a lot of women who are struggling with infertility. When you are the one struggling for infertility, you feel that it's just you, because there are so many women around you with children and stuff. So it can get very frustrating and demoralizing. And my first step, I would say, is don't get there. Don't let your mental state go there, because mental state is very important for success in getting pregnant. So whatever you can do, I know it's hard. It's easy for me to say. It's hard for somebody going through it to actually practice this. But for example, getting a regular physical exercise. Sometimes I've also said to patients, they're religiously, I know we've talked about, regulate your tracking your cycles, tracking when you're ovulating. But I've seen some women who are feeling they're infertile because they're not getting pregnant. It's been 6 months, and they religiously every day, the first thing they want to do is track their cycle and when they're ovulating. Don't let that become an obsession, is what I would say. Usually to that patient, I would say, take a second honeymoon. Just enjoy yourself. Don't even think about pregnancy, because a good mental state is really important for conception to happen. Now, there are women, they have other conditions that they can't get pregnant. So my second advice would be, don't wait too long. I know we women are career women. I am included in that. We have so many things going on for us. We are competing in a tough world. But don't, if you really are interested in having a child, don't delay childbearing. You can catch up. You can catch up with your career a little bit late, but that's okay. But unfortunately, your ovaries will not wait. Your ovaries, the eggs that you have in your ovaries, when your mom was pregnant with you, when you were you were 5 months old in your mom's belly, that's when a woman made all the eggs they were ever going to make in their lifetime. So your eggs are as old, if not older, than what your age is. And so the eggs only get older, and that can give you problems in getting pregnant. And so my second advice is, if you think you know, and you want to have a family, you want to have children, don't delay childbearing. There are many obstacles that can happen. You can develop fibroids, you may need surgery. So as soon as you can. I know life has different aspects. You know, you want to have a stable career, you want to have money to take care of a child, you want to have a partner. You may not have a partner, you can't have a pregnancy without a partner. So all those things are involved, but if it is in your control, then I wouldn't wait too long. um, Second, the third only advice I would have is, of course, take your prenatal vitamins, be healthy, and seek a doctor's advice in why you're not able to get pregnant. Sometimes just finding out if there is a reason that can be fixed is very relieving. So getting a workup, a checkup, like everybody has been saying in the panel here, you know, optimizing, let's say you have diabetes, just getting diabetes under control. And I think Dr. Jolett said just losing 5 or 10 pounds, just losing a little bit of weight may regulate your cycles. And that itself, it will get you pregnant. So I would encourage you not to get frustrated, not to let that get to you, and seek out a regular exercise, something that will take your mind off, and get you in a good mental state. And good luck to you who are going through that. And we are with you.
All right. Thank you so much. Really helpful advice there. And I know you mentioned focus on healthy, and turning to that, Dr. Jolett's question for you here. Can you please give examples of healthy diets? So things to prioritize eating, maybe things to avoid during pregnancy. And could you also talk about prenatal vitamins? I know that's definitely been mentioned. So it'd be helpful to dive into that a bit more.
Definitely. I have to say, I always feel hypocritical talking to people about diet and exercise when I'm definitely not the perfect model of that. The first thing I always talk about with diet with pregnant ladies is you're not eating for two. You know, depending on how many babies you're carrying, what your starting weight is, maybe what your activity level is like. The recommendations are a little bit different, but really anywhere from a few hundred extra calories a day, which is not a lot. So really just watching, you know, the quantity and not changing that, you know, as much as you might think. I mean, everyone knows the Mediterranean diet. So eating, you know, vegetables and, you know, whole fruits and whole grains and lean, you know, meats, poultry, eggs, beans. Those are all things that are important. Watching your processed food, fast food, just everything that's part of our American diet to avoid is really important. Watching your quantity, your servings. We have great nutritionists at Jefferson. Any patient that might need a little help or has diabetes or even just wants to talk to someone, they're really great at, you know, really putting into perspective, you know, the quantity of food you might have on your plate, or what you thought was healthy is really not, or has too much salt in it or something. So we have a lot of resources for that, but it's difficult, especially in America. We have a lot of fast food, a lot of processed food right in front of our face. And like we mentioned, a lot of us are working, we're career women. It's, you know, hard sometimes to be cooking. I also tell patients, especially if you're working overnight or you're a nurse or you're on shift work, really trying to pack your food, I think is really important. It's very easy to kind of get into a work setting where everyone's ordering out, and that's where a lot of that stuff's fried or greasy. So I know I do. I try to pack my lunch every day, and I think it really helps. In terms of things to avoid, I mean, most stuff in America is pretty well processed. We don't have to worry about that too much. Rules of thumb, usually we tell people to avoid anything that might be raw, sushi, things that might be undercooked. We don't really have this in our American diet, but things that maybe high in mercury would be bluefin tuna or swordfish, things like that. Most of us don't have to worry. We're not really consuming a lot of that. Definitely watching your caffeine intake. I have a lot of ladies will come in for their OB visit and they've got a huge Dunkin' Donuts coffee, and really you're looking at, again, our proportions are off here. You really want about 1 to 2 servings of caffeine a day. So really watching that, the Celsius drinks, like absolutely not. Just really kind of taking a new look of what you're consuming is important. Like Dr. Yondorf mentioned, prenatal vitamins. Everyone thinks I'm going to send in some special vitamin. I'm really not. Like she mentioned, prenatal vitamins are so important in the first trimester, and you should start them as soon as you're trying to conceive. That's the most important time to get that vitamin in. The important thing in the prenatal vitamin is mostly the folic acid and possibly iron if you're anemic, but the folic acid is really important. Other prenatal vitamins have vitamin A, B, C, vitamin K. They have lots of other vitamins, which most of us are getting in our diet, and through some of the fortified foods that we have here. But the most important thing would be the folic acid, and most of them are going to have that. But like she mentioned, you can turn the label around and just make sure it has enough of that folic acid in it. And whatever you can take. I mean, if the prenatal vitamin's too big, find a smaller one. You can do a gummy, especially in the first trimester, when it's the most important to get the prenatal vitamin down, but sometimes you're pretty nauseous. So just important to take and find one that you can tolerate.
All right, thank you. A lot of great pieces of advice there, and I really like the packing a lunch option. So thank you for sharing. Okay, now keeping along the same lines here, Michelle, can you talk to us about what a healthy exercise plan looks like during pregnancy?
I loved this question because I talk about exercise and pregnancy every day. And really, what's the plan look like? It's what you like to do. Exercise, it seems like such a chore in today's world. And I try to tell my patients that if you find something you like to do that moves your body, do it for 20, 30 minutes a day. So if you like to dance, go ahead and dance. If you're somebody who already exercises on a routine basis, whether you're a runner, you like weights, you do yoga, Pilates, continue to do that. Certainly throughout the pregnancy, you'll make some modifications based on where you are in your trimester, how your body is changing. That's reasonable, but truly moving daily, 20 to 30 minutes, stretches your body. That's so important. Getting the kinks out of your lower back and your hips as you get further along, especially in the third trimester, is so key. It does help quiet your mind too, which is really important. Some way to work out that stress from the day, whether it's a workday issue or a home issue, or just you feel frustrated that day. So I think exercise really should be that component in your life daily to some degree. I really like yoga and during pregnancy for many reasons. One, the alignment, helping to stretch your back, your lower back, and your hips back out. It also incorporates a lot of your own body weight strength, which is really important for fitness in general and toning your muscles for the act of growing further in your pregnancy, as well as during labor and recovery afterwards. And that's something that most people can do a quick 20, 30-minute yoga practice, varying levels throughout your pregnancy. One thing to remember too, if you are somebody who enjoys more cardiovascular work, you love to run, walk, do the elliptical, the Stairmaster, just making sure you're staying really well hydrated through those more intense workouts is important. Really increasing your water intake is key. Getting those electrolytes back in that you've sweated out during your workout. And also replacing the calories. Many of us focus on exercise outside of pregnancy as a way to lose weight, and we're working at caloric deficits. Pregnancy is a bit opposite. You need to get those calories and keep those calories on board. So you don't want to be working at deficits, but you want to replace them after those heavy workouts.
Yeah, that's a great point there. So thank you. Okay, switching gears here, Dr. Yondorf, I'll turn to you for the next question. What is the recommendation if a person is trying to conceive if they are on a low dose of SSRIs?
So I actually also really love this question because I think that unfortunately, in today's society, depression and anxiety is so pervasive and it's everywhere. And a lot of people are so quick to say, like, all right, just handle it, like it's fine. You don't need medication, just handle it. You can handle it. And I think that that's a little bit of an inappropriate recommendation to make because depression is a disease just like anything else. Just like you need your high blood pressure under control or your diabetes under control, you need your depression under control. And people don't recognize the effect that depression has on pregnancy. having uncontrolled depression in pregnancy itself. So actually having the depression that is uncontrolled, that disease has a negative impact on pregnancy. It increases your risk for miscarriage. It increases your risk for, small babies that aren't growing well. It increases the risk for preterm labor and preterm delivery. It increases the risk for C-sections and for operative vaginal deliveries. So the disease depression is something that will compromise your pregnancy. And so making sure that's under control is important. SSRIs are a super common class of medication. They're usually the first line medication used for depression. And because of how often they're used, they're pretty well studied. And, they do cross the placenta, they do get to the baby, they do cross the breast milk. So they do get to the baby, but the effect that they have on the baby is really not as bad as we all kind of once thought. Sometimes there's no risk really of teratogenicity to the baby. And what that means is like, we all are afraid that medications are going to cause the baby's organs or limbs or whatever to form in strange ways or to not form right. But so SSRIs themselves do not have that risk of causing any abnormal congenital anomalies in babies. Some of the things, the data shows that it might, lead to the need for the baby to withdraw from that medication. So after the baby is born, they may need to withdraw from the SSRI. And there's also a slight increased risk of the baby having trouble figuring out how to breathe on this outside world. So that transition into breathing, might be a little bit more difficult, but these are things that are transient and usually resolve on their own. They might need a little bit of support getting through that, but it takes only a couple of hours to a couple of days, and then the baby's kind of fine and on their own. It's also really important to recognize that depression itself has an effect after the baby is born. So there's a huge increased risk for postpartum depression. There's a huge risk for, abnormal infant development and abnormal child development because of uncontrolled depression during pregnancy and postpartum. And so making sure you get that under control is actually really important. And the risk of taking that SSRI is, the benefit of taking that SSRI far outweighs the risk of having uncontrolled depression. And so the rule of thumb is, if you're on something and it's controlling your depression, stay on it. Don't try and switch. Don't switch to something that like you think might be better. If it's working for you, stay on it. If it is something that makes you uncomfortable or concerned, you can reach out to, there are specialists, reproductive psychiatrists. So there are psychiatrists who specialize in reproductive aged women. And I would recommend, if you're nervous about something you're on, reaching out to somebody like that. Unfortunately, I think there's not enough information that's well known to a lot of different doctors. So kind of going to your primary care doctor and saying like, should I get off all my psych medications? Like, most likely they'll say, yeah, just get off all of that stuff. But going to somebody who specializes in this is one of the good things you can do if you're nervous about it. But in general, rule of thumb, stay on your medication.
All right, great. And I think that's really great news for everyone listening. So appreciate you diving into that. Okay, Michelle, we will turn to you. This next question dives into, how do I know if a midwife is right for me? Can a person that's high risk be seen by a midwife?
I liked this question as well. We are very lucky in our department that we have a collaborative working agreement with our midwives and our OBGYN physician colleagues. We work very, very well together. So I think most people could use a midwife, even if you're high risk. And, that collaborative care is so key to that. Our physician colleagues can manage and work with the high risk medical conditions while the midwife handles a lot of the routine pregnancy things, because even with a high risk case, you still have normal things that happen during pregnancy. Your body changes, your baby's growing. There's still things to expect: labor, contractions. What does that look like? And so we do work really well together. And I think that's really amazing. And we have a really great working relationship in that respect. The midwifery model of care really does focus on the normal physiologic changes that happen during pregnancy. And we try to look at this normal physiologic change in the global aspect of your entire health, including your medical issues. Being able to recognize problems when they do arise or medical conditions that might impact your pregnancy, and helping to guide you in that care along with our physician colleagues for high-risk cases is really key.
Okay, great. Thank you. All right. Dr. Condawal, we'll go to you. I know we touched on this a little bit earlier, but can you talk a bit more about geriatric pregnancies, including the risks associated with getting pregnant 35 years or older? And how does pregnancy care after 35 differ?
Can I just say that I hate that word geriatric? Because
Get
just
rid of it.
it's because you're 35, you're not geriatric. Trust me. You would call me geriatric, but not you. If you can still have a conception, you're not geriatric. So we give it a name also called advanced maternal age, which also I do not like. I wish we could change that. So whenever I talk to my patients, I always ask them, how young are you? Instead of asking them, how old are you? So I don't like that. However, to get to the question, I think what the a person is asking is, as a woman, age becomes older, how does that impact pregnancy care? And one thing we know is that as woman gets older, we've already talked about, it gets harder to get pregnant. There are some studies to show also, we've used the age cutoff as 35. There's nothing magic about 35, I'll have to tell you. The age we picked 35 was because way back in the 1970s, when we started doing amniocentesis to look for women who carry a child with trisomy. So as I told you, I'm going to step back a little bit and explain that a little bit more. So as you get older, I said women's eggs get older. When women's eggs get older, they get stickier. So our chromosomes, all of us have 23 pairs of chromosomes. That's what makes us human beings. So when the eggs get stickier and they make two eggs with 23 chromosomes in one and 23 in the other, they tend to make more errors. So they can put 24 in one egg and 22 in the other. And that's what, so if there are 24 meeting a sperm with 23 chromosomes, one of the chromosomes is now, instead of having two, you'll have three. And that's called a trisomy. So Down syndrome is like the number 21 has 3 chromosomes. So women, as you get older, at a higher risk. Even an 18-year-old can be at risk for it, but the risk of that is like 1 in 10,000, very low. But as you get older, so a woman who's 40, for example, has a risk of 1 in 40 to have a child with Down syndrome or a trisomy fetus. So the risk of chromosome, the reason we picked age 35, which is what people say here, it's not geriatric again, is because in the 70s, when we started doing procedures to detect whether the mother was carrying a child with trisomy, the risk of the procedure of pregnancy loss was about 1 in 200, and the risk of having a child with trisomy at 35 is 1 in 200, and that's why we use the cutoff. We don't want to cause more harm. We always want to do things that are more beneficial. There's risk to everything in life. And that's where the 35 came from. So I want you to say it's not a magic number. All of a sudden from 34 to 35, your risk doesn't go like a very high degree. It's nothing like that. It's just more statistical. But however, as you get older, and I think more important is as you hit age 40, there are higher risk, because as you get older, any person, all of us, as we get older, we tend to develop more medical problems. We tend to have higher incidence of hypertension, diabetes, and these are the ones that increase the risk of your pregnancy, and these need to be controlled and detected. There's also slightly higher risk of stillbirth. Risk of stillbirth, it's very low. Again, I don't want to scare any woman, because it goes from the risk of 1 in 10,000 when you're age 20 to maybe 1 in 1,000. So, or 2 in 1,000 if you get to 38. So the risk is not huge, but it is higher as you get older. And therefore, we tend to do more ultrasounds in women who are a little bit older. We also tend to do more fetal monitoring, or once you get to like 32 weeks, we do non-stress tests where we just put some straps on and listen to the baby's heartbeat for about 30 minutes. So we do some monitoring to make sure their baby's doing okay. We don't like these women, their pregnancies to go beyond their due date. So somewhere between 39 and 40 weeks, we like to suggest delivery, because we know the optimal outcome for any pregnancies between 39 and 40 weeks. That's what the current data shows. So as women get older, they do tend to get more complications. They're mostly medical complications. The fetal complications are more chromosomal and trisomies, which we offer testing for. And then we just do more monitoring. But otherwise, a lot of women can have healthy babies.
All right. Great, thank you. And I love that question. How young are you? So thank you. All right, Dr. Jolitz, we'll go to you now. Can you please talk about what is to be expected in the first trimester? Cramping, maybe symptoms coming and going, spotting, just to name a few.
Yeah, so most of our first trimester symptoms have to do with the really high pregnancy hormones that start to increase very rapidly in the first trimester. So most of us will experience nausea. Pretty much everyone knows that. Pretty much everyone mentions it. Usually that also includes breast tenderness. You might have some food aversions or cravings in the first trimester as well. Fatigue is a very common complaint. And I feel like I hear about it more with my not geriatric moms, but older moms, especially. Those are definitely the most common symptoms. You might also start to feel some abdominal bloating, some pelvic pressure. For some women, it's the first time they've been pregnant, first time their uterus is starting to enlarge a little bit. You might really start to appreciate that. And some of those symptoms actually can be more apparent when you've had children before as well. Constipation can be an issue even that early, especially with a prenatal vitamin that has iron in it. You might also start to experience heartburn even in the first trimester as well. Most of these, a lot of those symptoms, the good news is they will usually slow down or stop, some of them in the second trimester. Unfortunately, some of them continue throughout for patients, but spotting is unfortunately not normal, but definitely unfortunately is something that people experience a lot. Most of the time it's nothing to worry about. You can always let your provider know. Usually it's from a blood clot forming behind the placenta or for some other reason. Usually it's nothing to worry about. It usually resolves, but it is something to let your provider know and have checked out. But that's definitely not an uncommon symptom in the first trimester, and definitely is usually pretty light, might be pinkish or brownish. But I do have a lot of patients mention that, and that's usually something we don't have to worry about too much.
Okay, great. And Dr. Yondor, going to you now, I guess, what are some of your best tips for first trimester or pregnancy symptoms such as nausea, fatigue that was mentioned, et cetera?
Yeah, so like Dr. Jolitz said, nausea is probably the most common thing that I hear about when patients come in with their first prenatal visit is, oh my God, doc, you gotta help me. Like, I can't do this. I'm not going to make it through. First and foremost, most of the time it is limited to that first trimester. So the first 14 weeks is that first trimester. And usually by the time you're hitting that, 13, 14 weeks, it's starting to taper off. There are some unlucky women who really do struggle with it throughout their pregnancy. But most women really do start to see improvement once they hit that, the end of that first trimester. There are lots of different things that can be done to try and help, help you get through it. So there's a bunch of different changes that you can make to your diet that can be helpful. So instead of eating 3 big meals per day, you can try and eat more like 5 smaller meals per day, trying to space out what you're eating and make sure that you're getting food that's really got the biggest bang for its buck. And so protein-filled foods can be very settling for the stomach. And so nuts, I love to suggest nuts because they're bland, they don't have a bad smell. You get such a large amount of protein and nutrition in such a small quantity of food. So I think nuts are fantastic. If you can stomach it, cheese, yogurt, things like that can be very settling for the stomach. You want to avoid foods that are spicy or greasy or have a pretty strong odor because all of that can make the symptoms of nausea much worse. if those things alone are not really cutting it for you, our first line medical treatment for nausea is actually something that's pretty common and over the counter, but vitamin B6 and Unisom, which is an antihistamine that is often used for, as a sleeping aid. So those two things have been shown to decrease how frequently people will feel nauseous. And so taking it doesn't necessarily, when you're feeling sick, you can't take a B6 and you'll feel better. But if you take vitamin B6 and Unisom every night before you go to sleep, often that will help decrease how frequently you feel nauseous during the day. There are a bunch of anti-nausea medications out there. The most common one that we start with is Zofran, but there are lots of other options if the Zofran itself is not working for you. Zofran's great. It comes in a pill form that you can swallow, but it also comes in a dissolvable form that you can just put under your tongue. So if you really can't get anything down, just sitting it under your tongue, letting it dissolve can often help, make that nausea go away. A lot of times heartburn is a big component of the nausea. And so getting that under control can be helpful. So taking something like Pepcid, which is an over-the-counter antacid, can sometimes help decrease that nausea that you're having. There are times where, despite everything, some women will just continue to vomit and not be able to hold anything down. And that is something that really you should not just kind of shrug off. That is something that is not normal. And you should seek further medical attention for that. So that might warrant, if you really can't keep anything down, it really does warrant a visit to the emergency room. You might be so severely dehydrated that you just need some IV fluids to tank you back up. And then you can kind of be on your way. Some people do require IV anti-nausea medications for a couple days as well. And so definitely something to be mindful of, and not something to just shrug off as, oh, this is just normal. So yeah.
All right. Thank you. Some really helpful tips there again. All right, Michelle, we will turn to you. Question here: what is the number one thing you would recommend to prepare your body for birth?
This is a good question as well. And I think it really builds off of what we talked about, preparing your body pre-conception and during the pregnancy, but fitness being able to be physically fit, strong, limber, stretching, having those routine stretching sessions during your pregnancy to really loosen up the lower back and the hips, which during labor, oftentimes you're, with pushing, you're squatting or your legs are being pushed back or held back, or you might be pulling one leg up. And so being able to have some flexibility gained during your pregnancy so that you're prepared for labor is really important. Optimizing your nutrition as well. Again, for getting enough protein in your diet really does help the tissues be strong so that they can withstand that, especially with vaginal birth, the bottom stretching during the head crowning. There's also some evidence with perineal massage. That's where you're massaging the tissue of the opening of the vagina. That can help it stretch a little bit more readily during birth. And that's something that you can do in your, last trimester, like 36 weeks and on, with some olive oil and kind of your fingers and stretching, and also learning that sensation too is important. Being mentally prepared for the birth is a big thing. I tell people a lot of times labor is 90% mental and about 10% physical. It's how you approach your labor, right? Knowing that there's going to be an element of discomfort with contractions. Nobody's ever going to tell you it doesn't hurt at some point. There's going to be some discomfort. So being prepared mentally for what that might feel like, the feeling of your body taking over and going through labor. So learning some meditative techniques, some focused breathing, mindfulness, working with your partner to help engage you in those practices as well, to pull you back in if you're having a moment mentally during the labor course that you're not coping as well. Having that mental preparedness is really important.
Okay, great. And yeah, I think overall theme is prioritizing that mental aspect. So thank you. Okay, Dr. Jolitz, going to you now. What kind of pelvic floor work can a person do to prepare for labor?
Yeah, this is a really great question. I think pelvic floor work, exercise, therapy is definitely not talked about enough. Whether a patient's pregnant or non-pregnant, there's a lot of uses for it. Um, I've really never had a patient tell me they didn't, the pelvic floor work they did or pelvic physical therapy was a waste of time. Usually get something out of it. Like Michelle mentioned, it's just part of the piece of labor in terms of being well conditioned, but also having your pelvic floor ready to go. I have some patients who will see physical therapy during the pregnancy, and sometimes that's for pain, but also they can get you ready for childbirth. Sometimes they'll do breathing exercises with you, just work on getting your pelvic floor ready. It's a really good resource that we just don't use a lot and take some time, but they can definitely give you some exercises that you can do at home as well. So really with physical therapy and pelvic physical therapy, you're also practicing those techniques or moves that they've taught you to do at home as well. So you're kind of consistently doing that and getting ready for childbirth. It's also important for afterwards as well, especially if we're worried about a prolapse after delivery or your pelvic floor health, or for some patients, they might have pushed for a really long time. It's definitely a good resource for afterwards too, to prevent some of those things that are can be concerning after a delivery as well. I also think for pelvic floor, like Michelle mentioned, yoga is really important, especially for stretching with the pelvic floor. They have lots of videos online. I know Jefferson offers prenatal yoga, all of those things. I think just having a multi approach to it, working on your conditioning, but also your pelvic floor and your stretching are just so important, because at the end of the day, labor really is, it's labor, and it's an, an exercise of your body, and being well prepared for it's important.
Absolutely. Okay. Well, thank you. And I just want to say thank you to everyone who's been submitting live questions. We will be turning to those in just a minute. But for right now, I do want to turn back to Michelle for a quick question about birth plan. So what should a birth plan entail?
Fluidity in thought. So plan, I like to call it rather a birth like preferences. The plan is to have the baby healthy and in a safe environment. So I think the preferences are the things that you can really affect change in. So, how do you want the environment to set up? Who's going to be with you for support is the plan. Are there special traditions or religious traditions that are practiced at the time of birth that's important to you to practice at your birth is something to list down. Whether you prefer to labor without pain medicine versus with pain medicine. How much mobility are you seeking? What are your preferences when you're uncomfortable? Are there certain positions that you prefer to be in? Is something to put on your birth preferences. Most things that you find online about birth plans talk about skin to skin. At Jefferson, we do honor that golden hour. The baby comes out and goes right on mom's skin to skin. That's super important for baby to do that immediately after birth, to regulate their temperature and their breathing. And so that's something we already do. Delayed cord clamping is another thing that often you find on these plans, which again is something we routinely practice as well, as long as there's no emergency situation that we need to address with the baby. Being mobile is a key factor in a lot of these plans too. And we definitely is, again, something that we routinely encourage moms to do, patients to do, is to get up and move during your labor process. So I think these birth plans or preferences should sort of outline, what do you see that you would like to do? What is the experience that you're trying to have? Who is going to be with you, and what is their role going to be like, so that we, or your providers, also know where you're coming from as well.
Okay. Thank you. Definitely some important questions to consider there. All right. Well, now that we're at the top of the hour, I would love to hop over to some of those live questions that have been coming in. So I'll go ahead and just read out the questions, and whoever wants to jump in, please feel free and we will go through them here. So to start us off with the live questions, this person is wondering, what is the common average weight gain during pregnancy?
I don't know if you want me to take it, but
Feel free. Yep.
there is the American Institute of Medicine has recommendations, and in the last 10 years they came out with new recommendations depending on what your baseline weight is. So it's never, I think we've been saying this all along, is it's never a good idea to gain too much weight. Women who whose we go by BMI or body mass index, depending on your height and weight. And if it's really above 30, which classifies in the obesity range, the recommendation is not to gain, more than 20. It's usually 10 to 20 pounds. I usually tell patients, please don't gain more than 15 pounds in the entire pregnancy. A lot of women feel, I'm not gaining weight, my baby will not be gaining weight. And what I say is, a baby is a parasite. They will take everything from you. So you will, you will be harmed first before the baby is. So I think eating healthy, eating more protein, which is what the fetus needs for development, and eating small portions will avoid excessive weight gain. If you are very underweight, then it's okay to gain up to 30 pounds. But usually any woman who gains up to 30 pounds, I have to raise my eyebrow, because that is can be a little too much. When women carrying twins, again, I loved what I think Dr. Jolitz may have mentioned, you're not eating for two. I can't agree more. I can't agree more with that, because that's what we think, or we are eating for three now, so we can, eat more. Again, it's portion control, small, frequent meals. And with twins, you get more heartburn, more uncomfortable. So it's even more important to eat small quantities, just more frequently, and make good choices.
Thank you. All right, we'll move to the next question here, unless anyone else wants to jump in on that. Thank you, very helpful. So next question, whoever wants to jump in, can you please explain what gestational diabetes is, and is there a way to prevent it?
I can take that one. Okay, so gestational diabetes is actually this really interesting phenomenon that can happen to anybody. So there are certainly some women that we consider to be higher risk for getting gestational diabetes, but even those women who we would never even think would have gestational diabetes sometimes do pop up with this condition. What this condition is basically it's diabetes that is simply because of the pregnancy. What happens is that your placenta, which is that organ that attaches the baby to you and that feeds the baby, starts to make a bunch of different hormones so that the baby can develop better. And one of these hormones that it makes is called HPL, or human placental lactogen. And that hormone serves the purpose of trying to get the baby to have as much sugar as it can so that it can start to grow. And what that hormone does is it goes over to mom and it makes mom insulin resistant, meaning that her body will not respond as well to insulin. Insulin is a hormone that helps moms internalize the sugar so that their blood isn't full of high sugars. And so when this hormone goes from the placenta to mom, she is not as sensitive to insulin, so that her blood sugar goes up so that that sugar gets to baby and baby can grow. But what happens is that this becomes a little bit dysregulated, and the HPL will affect the mom to such an extent that she becomes a diabetic. So she is so insulin resistant as a result of this hormone that she can't really process the sugar anymore, and she struggles with the same things that we struggle with diabetes. And so that's what gestational diabetes is, and that's why it's something that really can happen to anyone, because it's related to the placenta making the hormone that it makes so that your baby can grow. which is why it's important for everybody to get screened for gestational diabetes, not just the people we think are high risk, but every single person when they get to that 24 to 28 week period, we'll give them that delicious, sugary drink and tell them you have to drink it. And some people are like, I don't need this. I'm not at risk for diabetes. And you're like, but you are, just because you have a placenta and it's doing its job. And so that's kind of what gestational diabetes is. What was the other part of it? What can we do to prevent it?
Mhm.
Again, living a healthy lifestyle, making sure that you are eating right and exercising can be helpful. But again, we see even skinny minis who struggle with the most challenging gestational diabetes because, can't do everything to prevent it, unfortunately.
Right. That was a really helpful breakdown, so appreciate that. Okay, next question here. Definitely, I like this question a lot because it kind of goes into the mental health aspect that we've been talking about. But this person is wondering, can you talk a little bit about tips for reducing stress during pregnancy when you're worried about all the different things your body's experiencing and will experience during labor? So any tips for preventing stress?
Yeah. So it's quite common. Yes. Stress during pregnancy. I think a lot of the anxieties of, am I doing what I need to do? Am I doing the right thing? Is my baby going to be okay? How is this going to change my life? Certainly creep into many thoughts during the day when you are pregnant. Ways to bring that down is ask questions. There's no better way to reduce your anxieties than asking the questions that are burning in your brain. That's what your providers are there for, family members. If it's something that's becoming a bit more pathological, you're getting overly consumed with worry and pervasive thoughts, then counseling is available. We are, one of the great things that came out of the pandemic is the plethora of telehealth mental health visits available. There are so many avenues to get counseling services. And so helping reduce your stress through counseling, talking to somebody is really helpful. Exercise is a great way to reduce stress and anxiety. Like I mentioned before, sometimes just being able to work it out physically and just get that, dopamine rush going and your adrenaline pumping, and really just helps to work out some of that angst as well. And then relying on your support system. Who is in your life that you can rely on to talk to openly about what it is that you're thinking about? Sometimes it's simply like, I don't know what kind of parent I'm going to be. And this is the thing that worries you all day long. And well, talk about it. What is the type of parent you want to be? What are your values? What is your family life like? Who do you look up to in that respect? And so being really open and honest and getting those questions answered for you can help really reduce anxiety and stress quite a bit.
All right, thank you. Okay, our next question here is going back to an earlier topic when we discussed caffeine. So this person is hoping to clarify what we mean by 1 serving of caffeine. What does that look like?
So 1 to 2 servings. So the recommendation would be like 100 to 200 milligrams. So if you're getting like a coffee drink, like a can, or something else that might have some regulations on the back, you can look at it and get an idea. Or like 1 to 2 cups of coffee would be another example. So, a lot of us get those, I get a big venti Starbucks drink, which would be several servings of caffeine. So looking at how much you're taking and then kind of trying to reduce that. And there's caffeine in a lot of stuff. So you'd be surprised. Some people don't realize it's in tea or other things. So really just watching that. I mean, you have more caffeine in one day. Is it really going to hurt anything? Probably not. But just watching kind of your overall consumption is never a bad idea in general.
Okay, thank you. All right, next question here. Can you talk a little bit about whether or not there are everyday products that need to be avoided during pregnancy, maybe certain makeup or skincare products, cleaning pet litter, just types of things to look out for and avoid, especially when it comes to chemicals? Any
So
thoughts?
go ahead, somebody else is taking it.
No, feel free.
I think there's very little data on it. Most skin products rarely get absorbed enough to cause a level or harm. I know we're always worried. If you're worried and it helps you, Megan, don't use it. But if you want to use it, I think there is no data and it should be really okay. Pregnant women usually should not be changing the litter, cat litter, because of risk of toxoplasmosis. In terms of, having other litter, just handling it should not cause a problem. If you have any concern, I would suggest you read all the ingredients and check with your OB. Even if you come to me, I will have to read the ingredients and look them up, to be honest with you, because usually as a general rule, anything that using your skin should be okay. If your skin can tolerate it, it's probably the absorption is very small unless you're bathing in it like crazy, which most people are not. So I think we think a lot of things are going to harm us, but really, really not. I mean, I think we get exposed to more radiation than we get in daily life than we actually have, and we get have an X-ray or something like that. So things are not as harmful as we think they are. And just using common sense is the best.
Absolutely. A little common sense. There you go. Thank you. Okay. Next question, and this actually might be a good question for you, Dr. Condowell. At what stage in pregnancy can you tell if a child does have a chromosome issue? And can you screen for that happening before you conceive? I know you had mentioned that previously.
So the answer is yes and yes. The only way you can screen for it before you conceive is, as somebody mentioned, you can have expanded carrier screening. So you can do mothers subject them to these whole slew of tests that you can do. It's called expanded carrier screening, and then if the mother is positive, then you check the father if they're carriers, and then you can suspect that there's like a 25% chance or a 50% chance that the fetus might be affected, and you can offer further testing. The other way to know before conception is to do IVF, and the embryo is tested. It's called PGD, or pre-gestational testing. It's diagnostic testing. Well, they'll take a cell from the embryo, one cell, and test it if it's affected or not. Once a woman gets pregnant, a lot of chromosomally abnormal fetuses miscarry. That is the #1 reason why women miscarry. I say usually, nature makes mistakes and they're taking care of it. But if you don't miscarry and move on, the earliest testing we can do is at 10 completed weeks, which is we call a chorionic villus sampling, or CVS. This testing can be done to look for chromosomes. It's an invasive testing. It does carry a risk. Everything does in life. Again, it's a risk-benefit ratio. If you're very worried about it and you're going to worry about it the rest of your pregnancy, I usually recommend getting tested. The risk of pregnancy loss is very small. It's 1 in 200 to 1 in 500. And some studies have even coded even less than that. So the risk is very small of pregnancy loss, but it's not zero. And then of course you can get tested anytime. You can have amniocentesis, which is usually done 16 weeks onwards, and where we take the fluid around. In chorionic venous sampling, we actually sample the placenta. We take a few cells of the placenta. In amniocentesis, we actually take the fluid that's around the baby, which is usually baby's pee, and some cells are shed from the fetal skin. So we actually when we aspirate the fluid, these cells are isolated and chromosomes are tested and grown. So those are the different steps when you can be tested.
Okay, great. Thank you so much. All right. We're going to go ahead and take one more live question for the evening, and then I have one final question for myself just to wrap up. But the last question is a good practical one here. Pregnancy and flying. When are you not allowed to? This person is wondering, if you have a flight and are 4 to 6 months, what would you recommend? And whoever wants to hop in.
I'm happy to take this. There's actually a ACOG bulletin on it. It's never unsafe to fly. our flights are very well pressurized. It's very safe to fly. So the flying is not the harm. The harm is when you're later pregnant in third trimester and you're flying somewhere and you break your water bag, for example, or go into preterm labor. Now you will be delivering in a place far away from home, and your baby may be in the NICU far away from home. So those are the usual concerns when you're traveling. Flying is not usually a concern because flying is very safe usually. They're pressurized, there's enough oxygen for you to breathe even at high altitudes. So flying itself is safe. When you're 4 or 5 months pregnant, you're pre-viable, I think it's completely okay to fly. Again, I am very pro pregnant women. I don't think we should put pregnant women in a glass chamber and isolate them. I call that pregnancy discrimination. I think pregnant women should be allowed to feel like normal people. And so there's no reason why you shouldn't be traveling or, going on a baby moon, for example.
Absolutely. All for the baby moons. So that's great. Okay. Well, thank you. And with that, I want to go ahead and ask my final question for this evening as we wrap up tonight. So I want to know, what are your goals for everyone listening in on this webinar? What do you want our viewers to take away from tonight? So Dr. Jolitz, we'll go ahead and start with you.
I would just like everyone to take away that just ask, go for that preconception appointment, ask the questions. If you're not sure if you should seek fertility help, come and talk about it. We might say wait for a year, or maybe your son needs to come in 6 months, or let's do it now. We have appointments. We want to talk to you. Don't let your fears or concerns stew and not get answered, because and we also have a lot of resources. And we've talked about so many things today, that we have a lot of resources for pregnant ladies, for pregnant patients. Just ask, and we can usually find the answer for you and get help, or further things. So
Okay. Thank you so much. And Dr. Kandawal, we'll turn to you.
Thank you for letting me go ahead of others. I just had to hop on to another webinar, but I'll tell you my goals for today is, I'm going to repeat what Jolette said, and it may sound like a broken record. Ask questions, ask questions, ask questions. I love it when patients ask questions, because, it makes me feel better, because if I forgot to say something and you asked, there, I get an opportunity again to answer that. So ask a lot of questions. Talk about breastfeeding. Be encouraged. Every mother can breastfeed. I know we go in with we have a feeling. I had it, my kids had it. I see a lot of my patients have it. We all feel that we're starving our children once they are born. Get enough knowledge about it. You're never starving. Every mother can. Most mothers, I shouldn't say every mother, but 90% of mothers can. So encourage yourself. Mental health. Recognize Kegel's exercises and regular exercises during pregnancy. You know how they say in real estate, location, location, location. In pregnancy, I say exercise, exercise, exercise. And so those, just knowledge is power. Gain as much as you can, and good luck.
Okay. Thank you so much. All right, Michelle, we will turn to you.
Yeah, I want to just echo my goals for tonight is exactly what everybody just said. I mean, I just encourage everybody to take the information that they've received tonight. Think about it. Think about how it applies to you. Ask the questions. We are here to answer them. This is a team effort. Nobody lives in a silo. And I just want everybody to know that we're out there for you and rooting for you, and want to support every aspect of the pregnancy and journey.
Absolutely. Thank you. And Dr. Yondorf, last but not least, any final remarks?
Yes, I think that just like everybody said, obviously ask questions, but one of the biggest things is that there is so much information out there online, and so much of it is inaccurate. And so I encourage you to do your own research and look up your own stuff, but please do not take everything you find on Google as, golden absolute. you can have your questions, you can try and start to look it up, but make sure you actually come to a physician who's gone through medical school and residency and years of experience and actually ask them, what they might have to say about it. So don't get fooled by all of the inaccurate information that's out there. That's why coming to webinars like this is so wonderful, because here you are and you have access to so many board certified women's healthcare providers. And here we are answering all those questions without, the fear of, inaccuracies of Google. So, that's number one. And then number two is be kind to yourself. This is hard. Being pregnant is hard. And, you heard us say a million times, eat right, exercise, no. But if you get home and you just want to collapse on the couch, that's okay. Be kind to yourself, because, you've only got one chance to do this, and you don't want to, drive yourself under.
Thank you. I think that's a great closing remark. Be kind. So thank you. Okay. Well, thank you once again, Dr. Jolitz, Dr. Yondorf, Dr. Condwell, and Michelle for your time this evening. Such great information was shared. I know I learned a ton. And thank you all for attending and submitting such great questions. We will be posting an event survey so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment. Stay up to date on upcoming events and webinars just like this one. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, innovation, and so much more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to previous before the bump webinars. A recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a great night.